old building there.
Hope so, innit?
Yeah.
Okay.
Yeah.
Thanks for joining.
No, that was excellent. Really enjoyed it. Thank you.
If you go out of this building,
Yeah.
but go out.
I mean, originally through a big hall with on the left hand side some kind of cafeteria, and then this big staircase.
I think so you get out, you exit.
Yeah,
Yes.
yeah,
And then look for the globe, so it'll be in that direction.
okay.
Yeah. I mean, it's a landmark, so anybody.
It's a landmark. It's,
Yeah.
it's a globe. Oh, like
Yeah,
a blob.
A natural globe, it would fill up the centre of that room.
Okay, and next to that globe, there is an
There is an
old
old
chapel-like building.
It looks
like
like a
red-
Victorian school.
Red bricks.
Red bricks.
Red bricks, okay.
Yeah. I'm going to do a minute, so I'll look up. You find
Okay,
it.
wonderful. Okay, perfect.
So, yeah, see you if not.
Sure.
Yeah.
No,
Oh, search party.
Sure. Okay, thanks.
See you later.
You want to send me that soft copy of you.
Oh, so sorry. Yes. You and both. I am so sorry.
Yeah. Then
Very
we
much
will
note.
do, yeah. So if you want to get something to.
So.
Yeah.
Good.
Yeah.
Yeah, keep the motivation going for the product.
Yeah. I've been actually writing one of the astros to get it.
Which article is this?
It's called. Yeah, because you know they give you time, so I can set in the visuals.
What?
I'm actually getting like a writing retreat. I'm just going to look at my good. Right. Yeah, it's a what I try to do.
See,
Yeah, I mean, really happy that I'll get to be. I was actually thinking of moving home when I realized I hadn't like moving countries. Both, yeah. So moving back to this US, but everything changed. Now it's been
it's a bit like that.
yeah. I'm
So
hoping
I
that
didn't
you'll-
Yeah.
Yeah, it's really challenging.
Yeah, because
Oh, yeah. I mean, in a way, for anthropology, but I wish yeah, I mean, and I was told by everyone to begin with that it would be hard on the first try, so I was I'd also completely get with it, but then I'm happy that I did. And so I think Edith, or Nikita's mentor. Yeah, I'm curious to see how that.
Did you email me?
Yes.
You want to
And do that.
I think maybe that's a great one.
Yes, yeah, I've got that.
Yeah.
Yeah. So Tim and Adi and John and Galaxy and Carol are all part of our match.
Yeah.
Galaxy and
We
Galaxy.
should hear them. I can hear us.
They can't see us.
They can see it. That's.
Oh, but if, oh, you can see Jason.
Can you hear us, John?
Hi, everybody, it's Valerie.
Hi, Valerie.
Psychotherapy.
You can see us, Andy.
Okay.
We can hear you. Yep, we can see you.
We can hear you. Can't see you though, but I can see the room. So maybe that's all you.
Dialogue training, I'm meeting a lot of different trainings.
Hi Valerie, hi Tim,
Really.
hi John. This downpipe or Stooky Blue that we're used to seeing. You've got a different backdrop color.
It's a good thing I'm not going bald. Yeah, not that I'm gay.
Depends which angle you look at, Anne.
So the relations to the.
Okay.
Yes.
I'm just gonna open the email that has the questions on it. And I can write. Who's in charge?
I think you're in
Who's in charge? All right, Valerie and Carol, do you guys want to turn your, if you can, turn your cameras on, but you don't need to. But you're welcome to. So, hello, everybody. Hello, everybody. My name is Anne, and I work in Newham Council with Jason and others. I was a student at the LSE in 2000. I've been shrunk our years by like 20 years. In 2000, we didn't have this tech, so forgive us if we don't use it completely effectively. What we're going to do is inspired by something called The Reunion, which is a Radio 4 program where people who have been together on a journey or same experiences talk about that. So I have a couple of questions for the panel. Who are these people? And then you're welcome to ask us questions or. So we'll do instructions.
Hi everyone, I'm Jason Strelitz. I'm Director of Public Health in Newham, in East London.
Hello, everybody. I'm Des, but I'm a Newham COVID champion.
On screen, do you want to start, Tim?
I'm Tim Wood. I'm a COVID champion from almost the very beginning.
True. Addy.
Hi everyone, I'm Adeola Agbayi, or Ade Agbayi. I'm a Deputy Director of Public Health, work in the same team with Jason and Anne in Public Health in Newham.
Fantastic. John?
Hello, everyone. I'm John Rook, and until November last year, I was Director of the Newham Health and Care Partnership and was responsible for working with our fabulous public health team in delivering such things like a COVID vaccination programme.
Small things. Valerie? You're on mute. Valerie, you're on mute. Valerie?
Hello, everyone. I'm Valerie Schutter. I am the Community Services Leader of Plaistow Seventh-day Adventist Church. We run a food bank. I'm also a COVID champion. I was a nurse that dealt with the first hospitalized COVID patient in London who came to Newham, who came to Lewisham Hospital, where I was working in intensive care. I also received a COVID award from my hospital. And I've been with Anne and the others since almost the beginning of the pandemic. And that's me.
Thanks, Valerie. And Carol?
Hi. Yeah, I'm sitting on the beachfront in Bognor.
Commitment. We have commitment in Newham.
I'm just sitting on the beach with an ice cream. There we go. So luckily I can hear you all right. It's not too noisy. I think I'm just an ordinary member of the public, live in East Ham. And I think I've been involved, it must be really since it started, the COVID champions. It just seemed like a good thing to do. So, you know, I attended Zoom meetings, you know, when I could. And also on one occasion, I was asked to help a member of the public who was afraid that if she got a vaccine, that she was going to be dead in 2 months. So I allayed her fears. I just think it was, you know, a good thing to be doing. Yeah, that's all I can say. Yeah.
That's amazing, Carol, because that takes us to our first question for all of us to, I don't know the best way to do this, and for all of us to talk about, which is, so let's reflect on the beginning of COVID, or at least kind of a month into COVID, or the early days of COVID, and how and when the Champions program came into your COVID experience. So how did the Champions program become part of each person's COVID experience? Does anyone want to kick off?
To give it a start?
Yeah.
Okay, so one of the first wave happened, and for us in London, it's can be hard to remember, but it happened incredibly quickly. It came incredibly quickly. We'd almost peaked in Newham and East London by the time of the first lockdown started, and it started to come down quite quickly. The lockdown was incredibly effective, and it had been shocking. This shocking thing had swept through the city, and as we reflected on the first wave, and Newham was particularly hit hard, it had one of the highest standardised mortality rates in the country from the first wave. We started to think about, what do we need to do differently? We don't know how long this thing is going to go on for. What do we need to do differently from what we did in the first wave to help, as a place, navigate the challenges of whatever's going to come next, an assumed second wave, and who knew what else? And one of the things that we reflected on was how the messaging, both from national governments and how we had translated it, I don't mean into different languages, in fact, I mean the opposite, how those messages had reached into our communities had been too ineffective. And also how we'd heard too little of what mattered to our communities. And and one of the reflections, we had to get closer as a local authority, and as partners like the NHS as well. We had to get closer to communities. And one of the ideas we had to do that was Champions. And we started to, we set up the programme, and Anne will talk maybe more about the formal setting it up, but that was it. That was started. It was all about how we get closer to communities to navigate whatever was going to come next.
Thank you. Any thoughts, Des, or anyone on the screen?
As being a nurse and having not ever been on lockdown because I worked throughout the pandemic, I was able to engage with the community in Newham and allay their fears, because, as you say, in the Black and ethnic minority group, they were saying it was something to kill them. And I was able to say, no, it's not killing you. I've had the vaccine. I'm still alive. I'm still working. I took photos when I had my first inoculation, my second, my third. I showed it to people, and I encouraged them for their health's sake that it was good, but not enforced it on them, but just showed them how it would benefit them. And a lot of people I know went and took it because they had that faith in me, because I'd had it and they could see I was fine. I never went on any lockdown, and a lot of people had it through their personal interactions, and it really helped the community. And being part of the Champions, we had the updates every week, and I was able to give them the update, tell them where to go to get their vaccines, tell them what type of vaccines were being given at which places, what age groups they were doing. And it was really a good way of disseminating this information out there to the general public, because let's face it, they don't believe what they read in the papers, they don't believe what they hear on the news. But if it's a one-to-one, it's much easier to speak to them and answer their questions. And I found it really, it was really humbling being part of this team and helping the local community.
Thanks, Valerie. I always sometimes forget that people don't know the specifics, because why would you? So just to say a bit more about what Valerie was saying around updates. So when we first set up the Champions, which was April, May of 2020, and there was no vaccine, we had 3 ways of communicating and listening to members of the public. So we had Zoom calls twice a week, one in an evening and one during the day, because people's eyes are different. And then we had emails that went out pretty regularly, minimum once a week, probably more than that, particularly when government rules were changing. I think we did 25 infographics that said, you know, keep Newham safe as each different policy change happened. And then we also had WhatsApp, which was pretty groundbreaking and pretty hard to get past our comms team. But because the mayor of Newham was quite clear that we could do WhatsApp, and because we knew about WhatsApp broadcasts, we could set that up. So that was that's the infrastructure around the champions. And now we still use email, WhatsApp, and we have a Zoom meeting once a month, because clearly the COVID messaging has sort of stopped and the general health messaging can happen at a less frequent basis. So hi, Tanzil is in Bangladesh, so she's hoping to join us as well. So Tim or Adi or John or Tanzil, do you remember in those heady days before the vaccine, where we had months of that? Adi?
Yep, I do. So just thinking about the sort of the kind of draft questions you kind of threw away, Jason's recollection of having a wave and then having a sense of how we get over that. And my role in this is, in the first wave, I was supporting care homes, and then from thenceforward, I was also supporting frontline teams and anybody else who needed it, to be able to stay safe with changing guidance and changing understanding. So writing guidance for people to be able to do resident visits as part of their job when there was no PPE. So that I'd started already my role in Pandemic about interpreting science and interpreting guidance and putting it into as human form as possible. And it was a natural progression from there to work with the first wave of champions with Zoom calls and with creating infographics to be able to disseminate information in ways that will be accessible and understandable to a really diverse public, using both visuals and as few words as possible, but there were still words there. And then working out how and where we translated and how and where we had those in the hands of community activists and community contacts that could do that interfacing and translating. Newham, as you may or may not know, is one of the most diverse, ethnically diverse boroughs in the UK. 73% of the population are a global majority. It's also religiously observant. 83% of people regularly worship in one faith or one of many. All faiths are in Newham. And we're also experiencing high levels of deprivation. There are very, very few people in IMD, index of multiple deprivation deciles, over the median point of 5. So that there are challenges. And as Valerie has already suggested, one of those challenges is that in some communities, particularly that have experienced discrimination and negative outcomes, whether as a result of deprivation or a result of racism, have low levels of trust in systems and low levels of trust in authority. So for having trusted messengers take easily understandable versions of the science into communities was absolutely essential for helping people to stay safe prior to vaccination, when the main way to stay safe was avoid catching COVID, please. And so we did a lot of that, a lot of trust building through those Zoom meetings that were facilitated with community, which is very, very important iterative process. Yeah.
Adi, do you want to say a bit about how enabling WhatsApp was, where there was this there was this pattern where someone would ask me a question, because I held the bat phone, as I like to call it. I could WhatsApp Adi and Jason and others who knew public health, because I wasn't, kind of steeped in the public health knowledge. And then they would immediately WhatsApp me back an answer, and then I could immediately WhatsApp it out to a member, to a champion, or to the whole group.
Yeah, so this was the big, for us, our WhatsApp messages haven't been requested by the COVID inquiry yet, but I
have them all.
But WhatsApp was a really important tool because it's so immediate, and its upside was it's so immediate. A champion could send a question to Anne could relay it out to any of the public health groups, and then any of us who had the expertise or were happy to go to Google and look up an answer. And I say not Google, but the internet and Google, because all of the journals, the peer-reviewed journals like the Lancet, the British Medical Journal, the WHO, Public Health England as it was at the time, it's now OHID and UK HSA, opened up their libraries and publications to everyone free. And the peer reviewing process for new evidence and science was sped up for the whole of COVID and the vaccine, so that you could go online and find reliable, up-to-date evidence and information about what was happening. So we knew in March in Newham that we were going to have difficulties, because we knew from the data that came from Wuhan that people with cardiovascular disease and type 2 diabetes fared really badly when they caught COVID, as well as people who were overweight. We knew that was going to be a problem. It remained as something as a surprise that never got flagged up in government guidance around groups who had specially to be shielded or given specific protections. But we knew that in Newham we have 10% of our population have type 2 diabetes, 30,000 people at risk of type 2 diabetes. So we knew that was going to be a problem. And in that first wave, we didn't have enough irons in the fire or enough levers and conduits in place to be able to quickly and effectively relay information into communities to be able to help people to protect themselves. But certainly for Alpha over that December and the subsequent waves, through the champions and through using better levers and having a more joined up campaign, we had better traction and better ways of getting information out. But WhatsApp was one of those. We could be reactive and we could be proactive through WhatsApp. And you had a really nicely curated specific champion group with the branding that could help send information out. And we could also get questions back and respond to them in real time. Work like this is quite time consuming. It relied on, in a pandemic, a team who were dedicated and devoted, and all of our goodwill to do this at 7 o'clock at night, at 10 o'clock at night, at 7 o'clock in the morning, as and when people had questions. And we did that. And we all worked crazy hours during the pandemic, but you have to when you have a crisis. So.
Yes, I was just saying to Laura, sometimes I'm a little tired. Tim, do you want to say something about the early days of the pandemic and why you decided to be a champion? And
yes, indeed. I think I was on my way back from the 6th funeral in 6 weeks, and when either I received an email or I saw a poster about the COVID champion, that I've got to join this, because I know the words to the funeral off by heart now. And it was a tragic thing, people of all ages dying as well, not just the old, but someone was 40, and it was a heartbreaking, tragic event. And what can I do to help? And the COVID Champions was the thing, so I can get that message out. I was a church warden at a church at the time. I had a network of 600 people on my WhatsApp group. I could disseminate that information to them, so they got, from the horse's mouth, as it were, rather than the gossip of Facebook and the inaccuracies of YouTube. Pre the vaccine, there were lots of groups, not necessarily that we might consider, but people who homeless people is one of my passions. And for instance, their lives were completely turned upside down. While it was great to get them off the street, they lost all their networks. They didn't have access to television. They didn't have access to internet in a lot of cases. So by using different points of contact, we were able to get the message to them as well. I think language as well. It's something like over 140 languages spoken in Newham, and English is by far not the mother tongue for an awful lot of people. And so using the COVID Champions, we were able to get the message out into language that people could understand, and that made a big difference on getting the messages out and getting the numbers down.
Can I just say something? Because a couple of key things that people have mentioned. So as he mentioned, trusted messengers, that's one of the things the champions are. And Tim mentioned his 600 on his WhatsApp group. And I think one of the key things was the power of information cascade.
Yeah.
So if we had 500 champions, it was about what did they do with a WhatsApp message once it came to them. And some would send it on to another 600 people. Some would print it out and put it up in posters in shops. Others would send it to, someone else sends it to every mosque in the borough. So it's that power of information cascade was one of the things that we were trying really to utilize.
Yeah. And doing it in a way that was easy. I just, on Jason's point, Tim actually put a Christmas infographic up in his church as the north, as the, whatever the star is called. Sorry, Tim, sorry about my bad religion. As the star over the manger in Christmas of 2020, which was, well, it was quite moving actually. Des, did you want to say something?
Yes, do you mind if I stand up? Can
Of
everyone
course.
see me to stand up?
Yeah,
Speaking about the
Yeah.
online, can you all see me okay? Yes.
Yeah, we can see you.
As my role as a community activator, that's my other hat that I wear. Community activator is just a person who goes out into community and tries to get people talking to each other and get more active and so forth. Well, as they said, in Newham it's quite diverse. There's a lot of people with different beliefs and religions and things like that. So I would go out into the community, get the information from the community champions, and sometimes, yes, I would print it out. Sometimes I would do it by word of mouth. I used to call it, say, pass it on, and that would get the word round. One thing I was quite impressed with is the accessibility of it. And there was some challenges, wasn't there? We had to work on it. For instance, BSL. Maybe you can talk about that later on. Also, from a person with lived experience of mental ill health, I was able to pass it on because there was a lot of people who was isolated, and as you all know, that it did affect everybody's mental health in one way or the other, or everybody knew somebody with issues around COVID. So for me, it was just brilliant.
thanks, Ed. We had a year into the champions, we had a celebration event, and somebody who had to shield because of physical health issues said at least it gave him something he felt like he can contribute, something he could do. And I think we'll come back to that when we talk about the way this program has lessons for the future. Anybody else? Tanzila, did you want to say anything about the kind of early days of COVID and the champions?
Thank you so much, and very good evening, everyone. So I think sometimes, this time are very hard, but it are also give us opportunity to work together, even we don't know that we can do or also contribute. And Anne and whole team are helping us and recruiting us, encouraging us whole time. This is like, uncountable. You can express the gratitude. So I'd like to say amazing experience. I had the earlier COVID time before the, the vaccine and things. And it was quite different. Like people are scared, people are, very stressed. So that time I like what the gentleman said about the mental stress that I feel for my community, because you can see I'm a Asian woman and my background is ethnic Bangladeshi. So there are lots of Bangladeshi community in our community. I mean our Newham Borough. So they know me and we know each other, and it's nice to be with the parents, with the women. I work with radio, television, so they know me. From there, they feel good to talk with me. So I was starting, you can say, mental health support session over Messenger, WhatsApp, email, and other online ways. They can navigate me, contact me, and talk about their stress and some really odd situation in home with in-laws, husband. It's really quite very hard time. In between, people can't go out. So I give them time and I give them information, make them assure you don't worry, it will be over one day. And I was working with a very elite people who working with hospitals, GP, and different healthcare. So I was invited them to, have time with me in my interview over the Facebook, and it was really went very well. So the doctor and the nurse, the midwife, they come and they talk everyday life. So can you imagine, they are fighting every day with the COVID, and we home, we scared. So it was really inspiring and amazing. The other way, a lot of people, the cost of living crisis, they lost a job, the earnings. So then I try help our community women. Why not you start something that you can sell through your community, and you can earn even a little money. And luckily, I mean, positively and amazingly, really they started online earning. Like they make things in home, especially cooking. People know different kind of cuisine and cakes and things, so they sell each other, they drop each other, and they earn money, and it was amazing too. I had some events and things, so in future I believe I will invite Anne. So anyway, so it was amazing, though it was hard. But how the community championship give us inspiration and empowerment, that whatever you can, whatever skill you can, still you can contribute. And yeah, it was nice. And Anne and the team always updated the information that we share with other people through WhatsApp, through Facebook, through group. And yes, it was really very positive outcome overall to contribute each other, helping, and be very supportive each other in the community, especially the niche community where they have the native language to speak and share and to be supportive as a friendly way. Thank you. Thank you.
Thank you, Tanzila. John to put his hand up.
Good timing. So I was just reflecting on just how uncertain everything was. And we had daily briefings, we had changing guidelines, we had lockdowns. At the very beginning, we weren't testing. So the sense of how to get a test and what it would involve and where one goes and what you do once you've had your test. We were particularly thinking about some of our NHS services. Some shut down pretty much completely and delayed a lot of care. Some were accessible in different ways. And what I think this program really helped me understand was how many questions people had about this environment, this highly uncertain environment, and how do I survive in it? And it was almost like we were co-producing live, which was excellent. We're finding out what people knew, what they didn't know, what they were fearful about, what they wanted reassurance about, whatever it was that came through, to then try our best into whether converting that into infographics or communication, or trying to get services to explain better how you can get a GP appointment, or what to do if you think you've got COVID symptoms, what you do if you're shielding, all of those things that enabled us, I think, just to communicate better, because we were getting live feed of what those questions, issues and challenges were from the people we were trying to support through our NHS, our care services, which then obviously led on to a very, very sort of bumpy and uncertain vaccination process that we tried to roll out in the borough.
I'm going to come back to you, John, because I'll go move on to the vaccine in a minute. There was one of the other things that was fed back to us, and please feel free to kind of add or disagree, was how valuable it was that people knew that the information came from Newham and was backed up by the Director of Public Health in Newham. And in the early days, we did videos each week where people just introducing themselves, not even about the information. So you sort of knew the faces behind the WhatsApp messages and knew it wasn't just my face. But there was something about it being credible. So it wasn't just information from anywhere, and local, that seemed to make a real difference. And as Addie said, we had a brand, and it's a very soft brand. It's a heart. And then as we got the vaccine, we put a little vaccine inside the heart. And if you look at our report, there are a lot of little things inside the heart at various stages. But that was purposely soft because everything we were seeing was so sort of hard and scary and bright reds and threatening. And this was about people coming together and supporting each other, as you said, Des. Okay.
So just, I think this is an important segue into the vaccine conversation. Yeah. Is what part of our brand was about building trust. Yeah. Right. So as Yoda spoke about it before, about, lower trust communities, lower trust, not with each other, but with authority. And one of the things I remember from the earliest days is, was just those Zoom environments we made very open. We would, myself or Adiola or John, we would go on the Zoom calls and we'd answer any questions. And if people asked questions that we didn't know the answer to, we would say, sorry, I just don't know, or sorry, we can't guarantee what's going to happen over the next 6 weeks. We just don't know. And I think people were a bit unused to public officials saying, I don't know. And actually, I felt that saying that helped build trust.
Yeah.
You know, it was honest. What we created was a totally honest environment, and I think that helps really build the trust between us as the public officials and the community. And we kind of all bought into this. We are on this journey together, and we're bringing our different expertises on this journey. And I think that was really important when we get to the next bit of the story, which is vaccines.
Did you want to?
No, it's just that, totally agreed, yeah. It's quite emotional actually thinking back.
It is. Yeah, we've had here moments. So let's go on to the vaccine. So just to give a bit of an introduction to vaccine conversations in Newham, I remember saying to Jason before the first vaccine had been given, we need to start talking publicly about the vaccine in Newham because people are starting to ask us. And we only knew that because we had the champions and people were asking in lots of different ways. And the NHS weren't in a position to talk because they weren't actually able to talk about what we didn't know. And so we could partner with the NHS, I'm pointing at John, whoever John is, we could partner with the NHS. There was a whole conversation, I don't know if you remember, John, where we were like, we won't grant this NHS, but we'll put you on the panel and then we can do it. And so I think just randomly, we had our first vaccine public Q&A on the day that the first vaccine was given. It was like the 6th of December or something. And we purposely, maybe it's the second one, but we purposely had slides that said, this is what we know, this is what we don't know. And immediately fronted up and were very visible about what we did and didn't know. So yeah, what are other people's reflections about how we started to use the relationships we built and the program to talk about the vaccine? Tim, you look like you.
Yeah, it was a great shame that we were slow in getting off the mark because the NHS weren't talking about anything. In the meantime, the experts with the white coat on YouTube were spreading disinformation, and so it was a bit of a struggle having to compete with that. But the great thing was, again, using that same network, that trusted network, that we were able to deliver the true facts that that we knew at the time about the vaccine, to encourage more people to take the vaccine when it was their opportunity, to explain the process, and also how those who were working in for instance in social care, who were frontline workers, how they could get their vaccine before to keep themselves and their patients and clients safe. So I think, yeah, but it was a struggle at first, undoing those fake backgrounds and white coats of YouTube.
Valerie, did you want to say, because you said some stuff earlier about being able to reassure people. Is there anything else you wanted to say about the vaccine?
Well, as I said before, I was working with patients with COVID when there was no vaccine. Granted, I did have very good PPI, but it was difficult. Everybody was afraid. And being in contact with people like on a daily basis, and people in Newham coming into the church for the food bank and asking questions and giving them the answers, and the trust that they had in myself and other COVID champions around the borough was really good for us. It helped us be able to give them the information they needed much more easily, and the trust they had in us made them take up the vaccine. And the whole team working together for good, and Newham seems to be way out in front of a lot of other boroughs with the things that we are actually doing for the populace of the borough. I don't know of any other borough who is giving out free vitamin D to their over 65, it's really good. A lot of people are taking it up and they're so happy about it. Newham is really a trailblazer in this COVID understanding for their people. It's made a lot of difference to the people in Newham. And as though we may not always hear them, but us, the champions, the feedback that we get from people, we know that they're really grateful to Anne and the team for everything they're doing for them. So Anne, I want to thank you on behalf of the people that I see, and Jason and Addie and everybody. Thank you all so much for being part of this fantastic team. I am really honored and to be part of this team. I really feel humbled that we are making a difference in our community.
Right, I'm just gonna have a moment. Carol, you mentioned earlier mid ice cream that there was a particular person in the public you'd helped with their vaccine concerns. Do you want to say anything more about that?
Yes, I think it was certainly someone that you asked if I could help. So I phoned her up, and she was from a minority community, and she'd heard from a friend of hers that if she took the vaccine, I think this must have been not the first dose, whatever it was, it possibly wasn't the first dose, that within 2 months she would be dead. So I said to her, you know, things like, well, why would it be 2 months? Why not 3 months or 6 weeks? Who was giving her this information? And gradually talked to her and got her to see that the person who was saying this wasn't a trained medical professional, and she should really listen to what a trained professional was saying rather than a friend. And then I found, as she was talking online, the actual figures. I can't remember, it was, you know, spreadsheets I used to download of the actual incidents, you know, and you could see how many people were reported, obviously reported, as dying from COVID, from allied things, or from the vaccine. And of course, I can't remember the figure, but the figure from the people dying that they thought was attributed to the vaccine were very small compared to the people who would die if they weren't vaccinated or caught COVID. So I think that finally convinced her. I might have sent that to her, I can't remember, but you know, I was actually armed with the figures. So that was the only, apart from, you know, ad hoc talking to people as I went along, and often they weren't people in the borough, it was, you know, anybody, you know, that was really, you know, the things that I try to do, just allaying people's fears and giving them the facts as opposed to, you know, all the gossip or the scaremongering, I call it.
So one of the things Carol's referring to is on the back of the Champions program, we set up a vaccine peer support program, which was again voluntary and was about people, members of the Newham residents, Newham public, and actually some staff and people from organizations who were trained in two things. One is how to listen and have conversations about fear-based questions. And the other was the top 10 things to know about the vaccine. Turning them into Jason or Addie or John, who have deep clinical understanding, but the kind of basics about the vaccine, and people would get referred, and they'd then have a one-to-one conversation that was completely, you know, unreported on their terms. And our role was just to put people together. We didn't kind of get involved in the conversation. John, as the kind of vaccine delivery person in Newham, I mean, everyone was, but a lot of it. Any thoughts from you on?
Well, I think what we'd amassed at the time of the vaccine rollout was a really good understanding from the people of Newham, who were heavily represented by the champions, about how individual conversations needed to be had to support people with their choices around the vaccine. And we had to relay some very complicated information that kept changing. So we had multiple different types of vaccine available to different age groups, licensed for different things. And we also had a very generic plan nationally about the rollout. And because our engagement with our communities and understanding about how people would react, it basically set us up with the notion that we had to break a lot of rules. So we recognised the uptake in Newham wasn't going to be as orderly as it might be in Northamptonshire or Somerset. So we invited people early in cohorts, for example, to use vaccine that had a shelf life. So we went wider than we should have done. We also recognised that people were very frightened to come out of their houses. And so particularly for the oldest age group who we vaccinated first, we spent a fortune on taxis. It helped our local economy because a lot of our taxi drivers had no business. But we spent a fortune on taxis to book people transport to get their vaccine, to make it as easy as possible, because we knew there was a level of being frightened about the virus, as well as being frightened about the vaccine. So just trying to take any barriers away that we could by talking to our champions, talking to representatives of our public about how we could do that better. And I think that really helped us with the how do we give the best possible information to people to support their choices, particularly when we were existing in a very uncertain environment around the vaccine. So we were learning what our fortunes were, what our supplies were, what was happening next around cohorts, at the same time as the general public from the daily briefings. We didn't get a cascade of information. It was announced there by members of government and we had to react to it. And as I said earlier, the ability for us to try and then smooth barriers, provide information, was really, really enhanced by the Champions programme and the questions you were asking, or the opportunities we took to talk to you as a group and realise where we still had, as Jason said earlier, we didn't know the answer, or we had to communicate this in a different way or take a different approach to it to help people. And one example of that is us saying we need to have as many sites as possible in people's communities in various different types of facilities. So whether that's a rugby club, whether that's a place of religious worship, just to try and make sure that we had all of those access points that would help people get to the vaccine and hopefully encourage them to have it.
Thanks, Lottie. Are we going till 3 or 3:15? Can you just
3:15.
15. Okay, cool. Anyone else on the vaccine? I'm going to move to the next question. Yeah.
Yeah, I could just say something very quickly. In my community, Black and ethnic minority, there was a lot of anti-vax people, especially, funny enough, from Jamaica. They were sending out videos just saying that it's going to kill us and it's going to maim us and women won't be able to have babies. And it was good getting information straight from the government, fed down, and it was great for us just to disprove it. Some people were still reluctant to have it, but I think we did a good job in encouraging people to actually have the vaccines.
Thanks.
So so in the social community in which I live and I have my children and they go to school and my friends, was a community that was the quite total opposite of vaccine hesitant, vaccine hyper eager, I think you would call it. Like, there would be WhatsApps would go around and say, there's a spare few vials going at a chemist 3.5 miles away if you want, and for people who weren't yet eligible, and people would chase after, they're hyper eager. And what really struck me, about 6 months in, we did a vaccine celebration, 6 months after the vaccines were launched, we did a vaccine celebration event to we came together as the vaccine champions to say what's happened over the last 6 months, what we learned. And it was the evening of testimonies where one after another, someone would come on the Zoom. It was a really well-attended Zoom, I remember. And one after the other, someone would come along and tell the story of how they had got to have their vaccine or how their parent had got to have their vaccine. And what struck me was, for so many people, they needed someone to help get them over the line. It might have been a son or a daughter, it might have been a GP, it might have been a fellow champion, it might have been a faith leader, but it was not a process of receive your eligibility text from the NHS and go to your appointment. It wasn't that simple process. It needed, whether it was due to building trust, actual translation, digital inclusion, all kinds of actually getting to the appointment, because we've got the lowest car ownership of the country. Whatever it was, everyone got up and spoke about they needed at least someone to help them get over the line. And that felt so kind of profoundly different to what was the experience in my the world in which I live outside of work, and that, yeah.
The other thing that I wanted to, about that event that was very different from what was happening in the national discourse and even the London conversation was that was an event that was involved Kevin Fenton, who was Director of Public Health for London. And he was going round London boroughs doing vaccine uptake events about why vaccination rates are so low in certain communities and what can we do about it. And in one of our other programs, which was, as John referred to, working with community groups to deliver vaccine in community locations, one of the groups had fed back actually to a colleague of ours that they were fed up. It was a Somali group. They were absolutely fed up of hearing that Black people weren't taking the vaccine. When 70% or 60%, it was 70% of Black people had taken the vaccine. Why were we constantly harping on about the 30%? And so we went back to Kevin. So this is a community group telling a public health official the message isn't working. And we went back to Kevin and said, we're not doing a vaccine uptake event. We're doing a vaccine celebration event. We're going to make visible the things people have done rather than go, well, you've done some, but you got to do more, particularly with communities where that message is constant, which is things we found in other research. And this idea, when is enough enough? And why are community members constantly being asked to kind of apologize for or find ways through national government rhetoric that isn't working? And that was a pretty big moment for us in terms of our orientation and our messaging for COVID and beyond. So now I'm going to go to beyond COVID, which is the world we now live in, and just ask from the panel and then open it up to you guys for questions. What do you think? We're already doing champions around cost of living. We've done it around refugees coming in from the Ukraine and refugees more generally, but I'm interested in panel's thoughts on, or the group's thoughts on, what lessons are there from COVID for other challenges, health challenges, public health challenges that we faced, particularly in a place like Newham, which, as Adi said, is majority, global majority, heavily faith-based, etc. So I don't know.
Did you want to talk about art?
Yeah, sure. Thanks for the opening. So one of the things that we did during working on this, and particularly working on thinking about combating inequalities and vaccine access and vaccine uptake, and John has mentioned about having multiple sites. We had a group that looked at this. We had different work streams, and we did driver diagrams and looked at the evidence and collected a lot of evidence about what some of the barriers were and what works. But we created a framework using the WHO. Basically, we took the WHO vaccine hesitancy framework, which is called the 3 Cs. And the WHO are really economical in their use of letters. They had a 3 Cs for COVID, which was brilliant. The 3 Cs for vaccine hesitancy was designed in 2014 by the SAGE, an international SAGE working group. By having to use a C, they had to use some sort of words that for us didn't work so well. So confidence is great. Complacency is not so good because it's othering, and convenience is not so good because it's othering. It's sort of like the word lifestyle. It suggests that it's a kind of a sort of a light choice about different sorts of tea as opposed to something much more substantial. So we took essentially the meaning of this and plus observations we'd made looking at various other issues, like, for example, prevention pathways around type 2 diabetes, and changed the letterings to art, accessibility, relevance, and trust. So this is now no longer placing the burden of responsibility for working out how to engage on the person. It's placing it on the service provider, that in order for people to turn up to your service or your prevention opportunity or your health opportunity, you need to make your service accessible. And that includes language and distance and opening times. It needs to be relevant. It has to have some kind of meaning or salience or relevance to the person's life. And it has to be trustworthy or trustable through whatever mechanism, which is a homonym for confidence in some ways. So we started to work with this, use it to code some of our data when we're thinking about looking at inequalities and uptake for services and service pathway deep dives and QI work. And we're still in the early days of using that and coding it. But at face value, it's a good and helpful tool. And it works not just for vaccine, but also for other prevention programs and other services. And again, it prompts services to think about people's lived experience when they're coming to access the service and not resort to sometimes the kind of slightly defensive narrative of blame the person that's not in the room, or ascribe something to cultural behavior if people don't turn up. If people don't turn up to a service, it's not their fault, it's yours. So it's about supporting services to think much more roundly and in a not defensive, provoking way. So about how they can shape their service offer and their communications and their siting and their timing to be able to make things accessible. And as John says, we knew we would need multiple access points because in a borough as deprived as Newham, people don't like to go a long way to reach things. A, they don't have cars, as Jason has said, but B, they don't like to go to an area they're not familiar with. You don't know where the threats and risks are, but you know they're going to be some. You don't like to go into an area you're not familiar with. So that going 4 miles across the borough for people is far too much. If you book them into a service in a face-to-face appointment at one edge of the borough, and that appointment is going to be at the other edge, they will not go to it unless for some reason that's where they already lived and they managed to be taken to that appointment. So we know that having from other behavioral science frameworks like Mindspace and EAST and COM-B, we know that in Mindspace particularly, messengers, trusted messengers and norms are really important. So we did a lot of work around trusted messengers where we have lovely anecdotes of people having the first vaccination in their life because it was in their place of worship, or having the first vaccination in their life for people who had very marked difficulties and learning difficulties, when that was with their GP in a vaccination centre and they were allowed to come in their specially adapted vehicle, and the GP came out of the vaccination centre and did the vaccination in the vehicle. And that stories were told and hands were held and special music was played and everyone could feel comfortable with the surrounding. And so lots of people were helped to get over the line by, from our terms, 1 or 10 minutes worth of additional effort, a little bit of co-location in a different way, a little bit of thinking about delivery in a different way. And all of those little stretches made a huge difference, made things genuinely accessible for a lot of people. And we're still unpacking relevance and trust a bit more.
Great, I'm going to Tim or Carol or Tanzila or Valerie, anything for you guys about what this means for the next
I think
phase, and then I'll open it up to questions.
Okay. You can't reiterate enough the fact that you've got to push to and think outside the box. Is use WhatsApp, explain that it can be done safely. Don't be afraid to go to faith groups, and if you want to be ultra inclusive, include the Atheist Society and the Agnostics as well, because they're all networks of people who can get that message out.
Great, thank you. Okay, I'm conscious of time, so anyone, did you want to say anything? No. Any questions for people? Go ahead and then go ahead.
I'd love to hear a bit about how you're using the community champions sort of method to work around cost of living crisis, because that seems like, given the context of Newham, and it seems like the sort of classic thing which cannot be addressed through information.
Well, so I'll answer that quickly. So first of all, we've stopped calling it a crisis. It's just a reality and it's going to be here for a long time. There are two things, and it's back to Addie's point about access, relevance, and trust. So first of all, people don't know what they're entitled to. So there is an information gap around accessing the services and benefits that you're entitled to as a member of the public, including emotional support from the pressures for cost of living. And the second is back to the trust part. We know, and other boroughs are seeing this as well, that delivering some of the information or having some of the conversations about the financial pressures with the council is not where people naturally want to go. And so they want to talk about what it feels like to be worried about money with somebody they know and have some advice about what to do about it. And so all of the mechanisms that we've built through COVID around multiple access points, champions as ways of getting information out and having difficult conversations apply to the cost of responding to financial pressures and the cost of living. Does anybody else want to say anything about the cost of living? And it's branded and it's infographic and Same, using WhatsApp, same mechanism.
I think it would be fair to say that there isn't, but for cost of living or any other, for various reasons, it's harder to mobilise the champions quite on the scale and intensity that it was during this. This was a particular moment of a kind of a collective burning platform for action. I mean, you know, Tim spoke about joining, having come back from 6 funerals, and people with not much else to do in their lives, stuck at home. So there was a particular moment in which it wasn't easy, but I think it was easier to galvanise collective action at scale and intensity. And I think, you know, back in the complexity of all of our day-to-day lives, whether it's cost of living or mental health or diabetes or the other things that we try and organise around in similar ways, I think a lot of the tools are ones we need to use, but it is harder to mobilise in quite the same way.
Yeah, that we're seeing quite a decent uptake on cost of living champion sign up. I got asked once whether we should do it for breastfeeding, and I said no, for exactly the reasons that Jason say. So it's issues that communities care about, want information about, and want to tell each other about. And from the statutory side, we know it's not conversations with officials. Laura.
Yes, I just wanted to say, and just to sort of put on record how important the Newham community champions were to SAGE and the government as an example, more than an example, a kind of exemplar of how to go about these programs. We first heard about it on SPI-B, I think, when you first started it up, and it became like, we need to know more about this because this could work at scale. And so it's because Anne was so kind enough to let me into, I think it was one of those really difficult conversations about vaccines, actually, that I came to that, and I saw the quality of the interactions and the fact that, as Anne has said, that there was a lot of challenge going on in those conversations as well, and there was a lot of learning going on the public health side. And I think as it kind of fed into the big government schemes of community champions, we tried to keep that co-production challenge in that, but the government started to understand it much more as just that cascading information. And in a sense, you have to talk that way to funders, and maybe that's okay. But I think what they didn't understand was that you can't just use communities. You know, there has to be really difficult, hard learning going on, which I saw some of that you were all going through at that time. And really, I mean, co-production is a big word, but it's really challenge and response. And I just kind of want to put that on record for all of you, for all of your community champions and Ade and, you know, Justin and Anne and all of you, that it's really made a difference to the whole of the UK. In terms of a kind of question, I suppose I wanted to ask community champions, and maybe, I don't know, Justin and Ade and Anne as well, has it changed your sense of who your community is? Like, have you felt like Newham, that your connections in Newham to people have changed through the work of doing community champions at all? Because we kind of saw when we looked at that in places like Kirklees, that basically groups that hadn't been collaborating with each other started to collaborate. So maybe, you know, in Kirklees it was kind of white working class group that was collaborating more with Muslim groups. And we also understood from those sorts of studies that community isn't that simplistic thing of like, it could be like a football club or, you know, and I think that was one of the learnings we had. So I just wanted to know whether it had changed your sense of being part of Newham, being a champion.
Valerie or Carol or Tanzila or Des?
Give someone a chance.
No, go ahead if you want to go.
Okay. Well, for me, I was a community champion, and so I would go around in the community and, as I said, encourage people to get together. But yes, this initiative, it actually opened things up. And for me, instead of just being local, you just sort of took off, it just expanded. And I found myself talking to other groups, maybe that I wouldn't be so much. And I think it just brought Newham as a whole together. I don't know if the other community champions would agree with me, but it was a sense of pride, actually, it still is, what we actually achieved through community champions.
I agree with the pride, yeah. Tim, did you?
That's great seeing different groups that you wouldn't normally interact with in your own little niche and what have you. But when we came together at Champion meeting, we could see that everybody's doing the same thing together, and it did bring us together as a borough, which was great, and brought certainly a lot of cohesion and understanding as well, which was very rewarding.
Valerie, did you want to?
Yes, as a member of a faith group, we have always been inclusive, but over this time and of being a champion, we are more integrated with the other religions as well, so that when they are doing things, we go and support them. When we're doing things, they come and support us. And we have got a really good interaction with all denominations that live around our church building, that we're doing all sorts of things. Now we're doing exercise for ladies only on a Sunday morning, because we've got a lot of Muslims around us and they will not come if the men are there. So we are now doing ladies only. Later they will start the men only, but we're doing things that include everybody in our community. And it's amazing how you just get to know everybody, you know, your local councillor and everybody. It's like we're all one group, and we are saying things with one voice, and it's really getting out there into the community. So it's been really very good being a champion, interacting with champions of other denominations, and the generality of the people in our community. It's been wonderful being part of it.
Tanzila, did you want? Thanks, Valerie. I think you're on mute. Oh, you are on mute.
Hello.
Yeah.
Can I share?
Yeah.
Oh, thank you. As Valerie said, actually it's amazing. It's wonderful to be with all the champions. All the champions are amazing, kind-hearted, and amiable. So it's nice to be with nice people and work together. Be part of a noble work. It's amazing, So it's a beautiful, be part of a positive, changes or contribution. So yeah, I just want to say thank you so much, everyone. Thank you.
Just to Carol, did you want to say anything? I don't want to interrupt your beach.
Actually, I'm driving, but luckily I can deal with it. No, really, people have said the things that I would say. I can't add to what other people have said. It gives you a sense of community and so on. Yeah. So yeah, let's see. So I'm still listening, but I'm driving, and if I need to say something, I've at least got a big flat mic. Right.
All right. And from a public health perspective, we're not going to get it. It's a very bad idea. I had two reflections on that question. And I'm looking at John, because I remember, so one of the things it did for me at least, in terms of connecting with the community is it made personal what felt quite kind of unpersonal at times, right? Kind of like, what are we doing across the borough around this issue? And there would be times when there was one champion who really needed his third jab because his son was I don't know if you remember this, John, his son was very ill in America and was in hospital. And he messaged me, I messaged John, and we managed to and he was eligible. It was just, and we managed to get him a vaccine the next day, and he was able to fly out. And there were moments which grounded this incredibly frenetic kind of population level experience in really individual moments that, at least for me, helped it feel like, okay, we're making an impact on this individual level. And the second thing is we used WhatsApp broadcast because you don't see each other's numbers. We also set up a WhatsApp group, and it now runs itself. And I kind of keep an eye on it because sometimes it gets a little overtly political, and I have to be like, come on, this is, and now it even does it. The other day that happened, and someone said, come on, this isn't meant to be overtly political. And so it actually built a set of relationships from people I've been told, but from people who wouldn't be talking to each other. And there were things, people lost family members, and that WhatsApp group, they would tell that WhatsApp group, and that WhatsApp group would share condolences. And there was some person who every once in a while just says, have a great day. And, you know, you're like, okay, good plan, I will. So that, yeah, really, both those are examples of, I think, a way it's changed, not changed, but created different kinds of connection to community for me.
Yes, I think I'm going to start from where you just ended, and I really liked your presentation. I've worked with community influencers and, you know, village health teams for many years. In 2020, I was a coordinator of a community of practice, working on issues, of course, of COVID, but also issues of sexual reproductive health. So for me, the major question, and bring research also on the role of grassroots organizing on issues of violence against children. One of the issues that is part of my reflexivity, and I want you to reflect on that, is the politics in it also.
Yeah.
Because you talked about the politics.
Yeah.
And one of the things, because I do a lot of work around reproductive justice, is also to acknowledge that reproductive justice is not just about information deficit. Yes. And so whether this community influencer can also act as interlocutors of the state. Yeah, because then we talk about the context of your work. Sometimes people also become very visible during crisis, like now, and crisis after crisis, that's when they become visible, but the structural issues are left intact. Yeah. So at what point in terms of your reflexivity also do you reflect on whether what you're doing is maybe just being seen as appendages of states and just doing the work that the states are supposed to do without asking questions and yeah, we are influencing, and I'm a man influencer also, but then, you know, deep down, you know, do we also enable communities to ask deeper questions that can also help, you know, address issues of inequalities?
So just I don't know if everyone heard it, how are we ensuring that this isn't just becoming extensions of the state? And in fact, this is a very live question in the next iteration of Champions across London. We've got a kind of a conference on it in a couple of months with the ICSs. So we were always very, very, very clear that the policies were set at a national level, and that is what we conveyed. We didn't go off piste, and I remember we had quite a few conversations, Jason and I, about this. We didn't go off piste and say something different to national policy, separate from, as John said, really pushing the boundaries of the vaccination program to be right for Newham. What we never said to Champions was, and then you have to use the information, you have to use it in this way. We gave people information and they chose what to do with it. And if they chose not to share it, totally fine. There was no minimum engagement requirement purposely set. And in fact, we had a Zoom call once, I don't know if other people remember this, where colleagues from London who were doing NHS 111 came and said to the Champions, here's a script, can you go make videos? And halfway through the conversation, one of our most active champions said, Anne, I'm not doing this. I'm not interested in this. This is not what people are worried about. And in fact, you're having a conversation between officials right now on my time. Stop. I mean, almost word for word, that is what she said. And she was absolutely right. And that has stuck with me and stuck with the program, that this has to be a really real intersection between what community members want to share with others and what statutory sector has as policy. And when one of those isn't there, it's not the right intervention. The politics around reproductive health is another conversation we're having with our faith leaders. On a Champions model, that's where we stood, and that's what worked. I don't know from the Champions sides what you guys think, but that was the internal conversation or lines that we drew.
We've heard a couple of times co-production used, and I think actually co-production, it's both sides of the argument, and it's as much listening as well as is, you know, talking, preaching, and that's why the COVID Champions was so successful. If it was just a one-way street message, we could have tuned into, you know, BBC World Service or something like that. But no, it was a two-way process, and how to make the delivery of COVID vaccines work for our neighbours.
I'm conscious that we're over time, and particularly to the champions who've taken time out of their other working days to join us. So thank you very much for having us. There have been multiple mentions of thanking me and the team. This is an incredible team effort. It couldn't have been done without, as Adi said, she said 7 p.m. She meant midnight, when I would message and go, does anyone know the answer? And Adi would be like, I know the answer, here's the answer. And so the generosity, you can call it co-production, I like the co-generosity between residents and community members and what sat behind the WhatsApp group was just incredible. And for me, it's been a deep privilege to be involved. I get quite emotional about it. A deep privilege to be involved and a deep privilege to see where it goes next. So thank you for joining the reunion, everybody on screen. And John from Cambridgeshire, it's so nice to see you. We miss you. And Tanzila from Bangladesh, we miss you too. And Des, thank you. And Carol from the car, don't come back on. And thank you so much. It's fun to be here. Have a good rest of your day. Bye.
Bye.
Looking forward to next step.
Bye.
Have a good
Bye, everybody.
and see you next time.
See you tomorrow.
Yes. Bye.
Nice. Thanks, Des. Nice. Thanks, guys.
I think we're at 3:30.
Guys.
There's a bit of a break, so.
Thank you.
We're here. Yes, we're back here. Actually, I was. Start now. Well,
without having to like look around like that. Yeah.
welcome everybody. Yeah, can you hear me okay?
Yes.
It's great to see you all here in the afternoon session. I'm going to sit there.
Oh, yeah.
Great.
So
We're going to start now. Okay, great. It's glad to see you all so energetic after lunch. And we've got a great panel here. And I just want to start by again underlining that today, Monday, is the beginning of Carers Week 2023, which is an annual campaign to celebrate the vital contribution of carers in the UK. So I think we should have a round of applause for that. All those carers out there. So we've got a panel here that are highly experienced in the issue of care. First of all, we've got Luke Tanner. You can put up your hand if you like, Luke. And Luke Tanner is a psychotherapist and a trainer and consultant in culture change and relationship-centered care. And at the moment, he's starting the London Circle of the Equal Care Co-op, which is a new experiment in care provision. And also from the Equal Care Co-op, we have Molly Iverson, who's part of the original Equal Care Co-op that started in Yorkshire. So she's going to talk about that. And then we have Elvis Mendes, who's worked in the construction industry for over 20 years, but at the current time is a carer for his 82-year-old mum. And he's involved with the Equal Care Co-op and his St. Thomas Church and Clapton Common in developing, you know, in an activist way, rights for the cared for and for carers. And we have Tony Collins-Moore, who's the Carers Wellbeing Academy manager at Carers Centre Tower Hamlets, has been working in this area for many, many years, since the 1980s, very experienced. And his charity provides services for unpaid carers in the borough. And we have Dr. Ileana Sarafian, who's a postdoctoral researcher at the Centre for Public Authority and International Development here. And I've been working with her on her grants to do with Roma communities in Leicester and London in particular. And she's also been involved in a British Academy grant on trust. You would have heard from her earlier as well. Great. So we thought we'd begin by just sort of 5-minute presentations from all of you about your experiences of care and the difficulties of care during COVID. So we're thinking about the past really, or you can present on your involvement with care and how you became involved in that as an activist. Or yeah, so care. We're starting with the theme of care and how that care was experienced. How you experienced that during COVID. Who wants to go first? Tony, do you want to go?
Okay.
Go to my right.
All right. So I've been working at the Care Centre for 13 years, and we had an academy where we looked at education and supporting carers to fulfil their caring role in a better way or a more comprehensive way. Anyway, when COVID hit, we had to completely change our approach to carers and how we work with carers. And what became apparent during COVID was that carers were working 100 hours or more per week. They stopped their care packages. They weren't allowing people in. They did everything. They were doing most things anyway, but they did everything. And so what we realized as well at the Care Centre was that the well-being of carers was actually paramount. So what we've done is we've literally changed our academy to the Wellbeing Academy. We've adopted the 5 ways of well-being, and everything we do, anything we develop, goes towards looking at how carers can promote their own well-being, because what we believe is that if their well-being is good and optimum, then they are able to be then cared for others, and there's less stress, anxiety, there's less health, health inequalities and things like that. So we use 5 ways of well-being. We use connection around peer support groups and condition-specific groups. We do learning. I'm working with the Open University at the moment to develop a carer's guide to learning, and an UCL around, and the World Health Organization, which was quite bizarre from the last thing, which was about developing a Bangladeshi toolkit on dementia. And I work with the London Borough Centre around mindfulness. We do counselling, and so everything we do, these are just a few examples, everything we do looks at the well-being of carers. And we did our annual survey, and doing it this way, there's been an increase of 28% in better well-being for carers. So all I would say is, and we've just done a big report to the local authority about investing in the well-being of carers is probably the best money you can spend, really, in when you commission services. And that's just me in a nutshell.
I'll go next. Yeah, so I guess prior to the pandemic, I was doing culture change projects, mostly residential care settings, older people's care and dementia care. So these were working with the whole organisation, and the focus in all our training and our work was on us, the care providers, the staff, not on them, the people receiving care or people with dementia. And it was really about, actually in the end, it was kind of it was removing all the institutional features that undermine the quality of the relationships and the quality of interactions in care. So that was a role that it was great to be in, because people often say, actually, oh, it's dementia care, that must have been so hard, but it's only really hard when you don't have any freedom or agency in your role. I was in a rare opportunity. I had a lot of agency in my work in dementia care, because it was about transforming service. It was about making changes happen. It's a very different experience of working in care when you have agency. I got interested in home care when I started to notice, whenever I did training with home care workers, I was very used to like care workers coming back and going, yes, but to any changes. But when it came to people working in home care, their yes, but always sounded so reasonable. It was like, yes, there is too many sort of structural factors which are preventing you from doing anything meaningful in your work. Unfortunately, around the pandemic, because all the care settings went into crisis management mode, actually a lot of them often already were, but it meant there was very little care settings involved in wanting to be doing culture change programs. So that's when I actually had 2 years of not visiting really a care home. And I used to spend 3 days a week at least in a care home working on these projects. So that's when I got more involved in a bit more over that time, working in the community. Actually, I was furloughed for a bit. So I'd say that actually the pandemic, I realized that we probably all talk about how it impacted our care networks, if you like, in different ways. For some people I've met, it stretched or broke their care networks to them. And for mine, it expanded. I was furloughed, I had time. I developed relationships in my community in lots of different ways. And it was actually, that was the beginning of starting to focus on more a cooperative development of a local home care service, working with Equal Care in Calderdale, who first I got in touch with before the pandemic, and then they were really too busy to help with getting anything going during the pandemic. But we tried, we did as much as we can without anything really, with a group of volunteers, really going from that appetite that people had around that time to sort of make a difference in their community, feel more, and people starting to feel more accountable to the well-being of the people in their neighbourhoods. So that's really when we start to build a network in Clapton, in Hackney. And we've recently finally got some grant funding to do what we were trying to do for a couple of years, but for this time with some resources and unfortunately a lot more accountability. Yeah.
Hi, yeah, I'm Molly. I'll talk about Equal Care Co-op to start with, then I'll talk about myself a little bit. So Equal Care is the first like cooperatively owned like giving care and support service. I officially started in 2019 and then was immediately hit by the pandemic. So it's a little further behind than what it was like originally projected to be. And then talking from like my experience working with Equal Care, it's just fantastic. Like honestly, very innovative. I fully believe in like the direction it's going in, and I'm very hopeful that it's going to change like how social care and like just care and support agencies, like their downfalls at the moment. Equal Care have sort of done the opposite of. And yeah, we're very accessible because we have a cooperatively owned platform. So if you just Google Equal Care Co-op, like you'll find everything you need to know about us. And you can join as a member if you know people looking for support or people looking to give support. We currently are only like officially functioning in the Calderdale area in West Yorkshire, but as Luke said, we've now got a circle down in is it Clapton? Yeah. And the eventual goal is to be like national, like everywhere, and then maybe international. Let's see. Me personally, so I've worked in the care and support industry for 3 years. So I jumped in actually during the pandemic when I was furloughed from a completely unrelated career direction that I was going in. So I've been a care worker for 3 years, but I've also been a carer for many years before that. My first experience of social care was via my granddad, who had vascular dementia. So I was a part-time carer for him. He had care workers coming in as well, and the rest of my family, we worked together as a team to support him. So my perspective is very much like, we was discussing not liking the terminology frontline care worker, but that is what I identify as. And also now through Equal Care, I am a team starter, which means I meet people looking for support and build teams of our workers around them. We do like matching, because we're the be all and end all of Equal Care is that we are relationship centered care and support, as opposed to person centered care and support, which means we're mutual. To the people giving and receiving support are both just as important as each other. Yeah, that's me.
So good afternoon, it's really great to be here. I'm going to tell you 2 stories. So the first story is about myself. So in 2019, I was diagnosed with prostate cancer, and it was a very successful procedure. I'm a textbook procedure, fully recovered. But in my recovery time, my mum was becoming frail, and the logistics of it, I live in Manchester, she lives in London. So in November, I found myself coming down to London just to support her. And then I found myself really at the sharp end of care, because everything just fell to bits. So I have a wife in Manchester, and I am commuting between London and Manchester, and I'm facing knockback after knockback in terms of how do I take things forward with my mum's care. Having said that, fast track to today, my mum was part of a local community church in Clapton, and her vicar was always somebody who was outward looking in terms of supporting the elderly, and he's carrying this sort of vision for the last 4 years. And when I came down, he said, look, I really want to support you Elvis in this. And just like a jigsaw puzzle, we're just having this sort of one-to-one. And the community activist called Marcus met Luke, and we just sort of got sat around the table. It was just amazing that Luke's vision was something that the vicar was carrying for 4 years. So when we got together, it's almost like a jigsaw puzzle come together. But the phrase which a lot of people know is it takes a village to bring up a child. And I'd like to think that it takes a village to care for the elderly. And I think that's what Equal Care are trying to put together in their pioneering sort of pilot, to sort of incorporate this within society. So that's basically my story.
So we started this research mid last year. We wanted to focus on stigma and how the Roma community in the UK, specifically Leicester and in London, was affected by the pandemic. In the process, though, as it happens in ethnographic research, we came across other themes, and we landed on the theme of care so far. And we traced those maps of care that are usually unseen, and I'm here on the outlier because we looked at care capital that is usually unrecognized. And I'll give 3 examples or domains where care is given, provided, and we usually don't see it as care per se. So the first one comes from young Roma children. So what we found that the children of newly arrived from people here in the UK actually have very higher social capital than their parents, in a way, because they would speak the language, they would have peers who are British, who are well settled, and they would be the one who usually would cook and clean after school, who would be looking after younger siblings, who would be organizing the vaccinations of their parents if they were willing to, who would be talking to doctors, who would be translating for their parents during their parents' meetings as well. So they would be managing medication as well. So a lot of authority was bestowed on these children that we came across. But also that was a huge responsibility. And in the narratives that we've collected, we saw that the children during the pandemic, especially during lockdown, were completely disconnected in a way. Many of their parents would work even under lockdown. In Leicester, for example, they would work in sewing companies, small ventures that would work 24/7, basically, because there was a demand for this during the pandemic. And these children would look after themselves, after their siblings, after the elderly at home as well. And bearing in mind that the Roma community is a community more likely to suffer with diabetes, heart disease, mortality 10 years younger than the general population. So, and here there was a disruption when the schools closed. There was a disruption in care for these children who found some form of relief by going to school, actually. So there was that disruption in care. And the second part, kind of the second domain that we found, so this is the children and their capital. Often we don't see teachers as carers, actually, but when lockdown happened, teachers who play a central role in the lives of ethnic minority children, usually who direct them either to public authority figures or to local services, couldn't be in touch with those children. So the teachers who we interviewed, for example, would say, because of the lack of digital access, we couldn't reach these children anymore. We couldn't go out. It was all online. We were disconnected. So I'll give you an example. When a child came back to school after the lockdown, the mental health of his mother was exacerbated back at home. The teacher sensed that something's happening with this child. She talked to him, and then the appropriate care was necessitated for the mother. But what the teacher said that during lockdown she couldn't. That wasn't possible. So there was that discontinuation of care, of carescapes, as we say. And the third kind of domain of care that is quite unseen, I think, still, but more visible than others, is the role of the church. Like you said, the local Roma church, it's not even a registered organization. It's an official, informal setting with about 200 people attendance who go on Sundays. They gather in a food bank building. But this is the only place, the only social infrastructure where people can share either food, or they can talk to each other about where to get services, how to get healthcare. So, and it was the church during lockdown that actually the pastor who was collecting money from people to cook, and to spread food to those communities who are otherwise unseen, completely unseen, under the radar of either local authorities or the community as a whole. So yes, so this is kind of in very general terms the research so far.
Thank you very much. Thank you. As you've all been speaking, it's probably struck me as probably it has other people in the room that, you know, both the Carers Academy and the Equal Care Co-op are such important ideas, and I really wonder whether you can maybe reflect on why care is so invisible in our society and the needs of care are so invisible, and why, in a sense, you're having to sort of reinvent ways to look after the people who are caring. I also have a question about whether it's possible to join together the needs of unpaid carers and paid carers, or whether that's an unbridgeable divide. And I'd like to hear, you know, from people who've experienced, like Elvis, who've experienced difficulties in gaining care, how when he's been made to feel invisible, and what have been the greatest barriers for him to be being seen or needs being seen.
So I'm also a carer, and there is a difference. So bizarrely enough, I'm a qualified care advocate, and I know my way around the system. But I had trouble engaging statutory services for my parents, and knockbacks and serious knockbacks, and then trying to tell me their version of the Care Act. So I didn't say what I did. I just went for it, and then I kind of stumped them a bit by saying, actually, this is how it should be. But so the issue I always have is, if you don't know the system, which most carers don't, how do you negotiate your way through? How do you get the right packages for your loved ones? You know what I mean? And and the other thing that I will say is that carer services like mine, it's not a level playing field. So in some boroughs or some counties or geography, it's a phone number if you're lucky. Do you know what I mean? We're quite lucky in Tower Hamlets. We have a physical centre with a staff team of 15 people, and we all do different jobs. But I do worry, and I've always worried, even when I work there, is that I spend most of my time advocating for carers as well as developing wellbeing initiatives, and part of that is advocacy, and I think it's difficult. And I think there is a huge difference between a paid care worker and a unpaid. And so there's a huge difference, and it's not about the money, it's just about what happens. You know what I mean? I think there is a role for paid care workers. My sister is a senior care worker, she's been doing it for 25 years. So, and that's another issue between my sister and I. We had everything sewn up, experientially and qualification wise, but it still wasn't enough for our parents. Do you know what I mean? So, and I was told that I couldn't register as a carer for my dad because I only dealt with him from afar. So, do you know what I mean? So, and somebody who said that they were part, can I just say something?
Yes.
From a carer perspective, when you say I'm a part-time carer, no one's a part-time carer, you're just a carer. Do you know what I mean? So, do you know what I mean? So I just wanted to correct you on that. There's nothing part-time about caring. So
yeah, I suppose I said that in the context of not wanting to seem as though I was the sole carer for someone. I guess I was trying to recognise that.
No, I know. I was thinking,
But to be fair, that brings me. You asked about how to bridge the gap. I think Equal Care, I hope, is doing quite a good, making quite a good effort of reaching that gap. In the structure of the teams that we build around somebody that's being supported. So when I say a team, I mean, you know, workers that have come through or work with equal care, because we have independent self-employed workers, we also have employed workers, and carers for those people, so family members, friends, peers, other agencies can be part of this team, services like, for example, a physio or an OT or a GP, they can be part of this team. And at Equal Care, we have a platform where essentially anyone can be a member of this platform, with the permission of what we would call a team owner, that's the person being supported. With their permission, anybody that they consider a part of their team can become a member of the platform. That means that they've got access to Rocket Chat, which is essentially like WhatsApp, but more private. And the Rocket Chat groups exclusive to the team owners, where we keep our notes, we communicate with each other within the team, logistically, and also it's kind of nice to just have that camaraderie, like, because there's so many different angles that someone can give support from and be cared for by. I think having these teams at Equal Care is our effort to bring it all into one space, and that space is very visible to the person being supported, because I feel like, don't get me wrong, sometimes people don't want to know what's going on, like sort of behind the curtain, but a lot of times they're not given the option to, and those decisions are made away from them. And yeah, and also in terms of the difference between carers and care workers, I have to say from my personal experience, one of the biggest differences I found is being listened to by services. For example, social services. If a family member, I've done it myself, I flagged up safeguarding for my grandfather as a family member, got nowhere at all. Flagged up the same safeguarding as a team starter at Equal Care, actually got listened to. Yeah, that's the difference, and it is unfair. It's very unfair. It doesn't recognise.
It's also illegal.
I'm not going to say where I did it or who to, but yeah.
It happens in healthcare as well. That's across the board, it's across all the agencies, sorry.
The thing just to elaborate on that teams model is just to give you a picture. Some of you might not be familiar with how home care normally operates, but usually it's an individual visiting another individual in a household and delivering kind of care. That individual, that care worker, doesn't usually have any freedom or control over their day. They're sent to a number of places in very tight time windows. They don't necessarily have any means to communicate or connect with the person they're supporting's wider support network. So they're supposed to support now the well-being of this individual without collaborating or connecting to that person's, if you like, the networks that might sustain their well-being or be part of play an important role in that. And so with the teams model, what we're trying to do is, you know, actually care always happens in a team, and the team is made up of carers, care workers, neighbours, but what we're trying to bring is, just like during the pandemic when you saw mutual aid groups sort of using WhatsApp, because we're a care provider, we have to bring a bit more scrutiny to the way information is shared. So the platform in a way is being built to enable a sort of more networked, decentralised sort of coordination and modelling of provision of care, but in a way which meets CQC requirements and local authority regulations. So we couldn't use in an official Equal Care team WhatsApp for various reasons or other platforms. And at least with the if people collaborate through our platform, the team owner gets to decide exactly who can see what. So they can set the permissions. So it's been built in mind. So most platforms for care work agencies are built with a sort of more centralized remote management control. So it's a platform that enables a manager, gives them control and oversight over the care. Whereas with our platform, it's shifting power and control to the care worker, the family care and the recipient of care. So that's the sort of teams model. And in Clapton, what we're trying to do is build on that. And we're looking at how can teams actually be more embedded in a wider local landscape of care and support. So how can we make it an even more networked experience of care? So that's the pilot we're doing with the help of Elvis in a community that his mum lives in, and actually and I also live in. Is figuring out ways. We're actually starting with mapping. We're putting we want to put teams on the map, and care teams should get the same, if you like, status and recognition as any other voluntary service or organisation, but they're invisible. So home care is invisible. We're trying to make it more visible and more integrated into a network. So that's the kind of experiment we're beginning.
I think you asked the question, how does it make me feel as a carer, whether I'm heard or whether I feel I'm supported. And I think it's all about community. That's what I'm learning, but it's so much to do with community. And like I mentioned, within the first week of meeting Luke, we sat down and did a mapping exercise based on me, and it really opened my eyes on how community is really important in terms of I as an individual supporting my mum, getting lost in this vacuum of just being focused on my mum, but not being cared for. And so very quickly I put in place for myself self-help, and it's purely because of the mapping that Luke did. So I'm part of a men's group who meet on Zoom every Monday called Mental. They're based in Stockport in Manchester, and we just talk about issues that men are going through. And that helps me to be able to function, not to be isolated, and to share things that are really, really emotionally and mentally challenging. So I think community, out of lockdown, there's a lot of little things which began to happen. Community seems to be shaping in different ways, and I think that's a positive.
I was going to say, I totally agree with you. So one of the things that did happen within the carer centre is that the carers themselves developed their own WhatsApp group and a community within a community. And I think they've got something like 150 people on a WhatsApp group, and they send each other positive messages every day, and they help each other out. And then they use it I use it with one of the people to say, don't forget there's a certain activity on today if you want to come in and join in, or they'll come back to me and say, so-and-so's dad passed away or something like that, and then we can reach out. And it's been really, really interactive with a charity, a recognised charity, but also an informal community group that's developed out of COVID, and it's been really good. Yeah, really, really positive.
And I suppose what you're doing is you're making absolutely visible both to the carers and to the person who's being cared for, the importance of these relationships. And obviously you can imagine a version of this people care for mapping that would include the young adults who are supporting their own parents as well. So there's a real flexibility to the model that breaks through all of those barriers and shows that each of these forms of care are making some kind of contribution. So care work may be different from unpaid care work, but there's a place for both of them. And Luke and I were talking about that just by coincidence a few moments back before this began. We were talking about the role that a paid carer can do for someone who's suffering from dementia, who can really take care of that person in a kind of neutral way without that sense of grief and loss about the person who has been lost. And there's a kind of equal role for the person who's paid to do that.
I'm just going to say actually a bit relates to all the different care labour that the children were doing in Roma communities. I guess one of an exercise, if you like, that precedes the care mapping that we do is a really short exercise on seeing care, and it's just a sort of circle with like lots of separated into pies, little segments, and it highlights all the different types of care labour that we all do in one way or another in our lives. And it was the first time I used that tool myself, and suddenly, you basically colour in the pie. How full is your life with family coordination? How full of your life is with medical activities? It was the first time I actually really wrote down or thought about the different forms of care labour. And I guess having being a new father, it's taken me a while for the penny to drop. Just how much, for example, family coordination, planning, just planning, making sure my kids get this or that, it was a lot of it happens very gendered work behind the scenes, and it doesn't get recognised and it's not talked about. So I really wanted to, since then I've been a bit of a care activist in let's talk about seeing all the different forms of care labour that are out there. So I've been doing that exercise as many people can. It's quite a provocative exercise because you can imagine it highlights just how much or little certain people in your care networks are doing.
You asked about why care is so invisible, and that's a complex question, but it's important to think of care also as an HUD too. So social listening is important, and I completely agree that money is not everything, and it's not really about paid and unpaid care, although this is important. But it's also about recognizing that some layers of society can be more marginalized, and they can be more deprived, and they can have less access to even simple, taken for granted facilities that others. So I'll give you an example, and I think it's because it's about moralities as well, in a way. So because care has that moralizing connotation, and that's why we don't talk about this, don't we? So a young school boy, 15 years old, constantly goes into detention, and when we interviewed the teacher, she said, well, I just don't know, I don't know what to do with him, because detention is the only way, but I need to speak to him, I need to hear from him, tell me about the Roma community. And there is a real willingness, I think, on the part of teachers to understand more about the community that is not very well understood here in the UK. But what was happening in the life of this boy was that his mum was made redundant during the COVID-19 pandemic, and he after school he found a job in a pub. So stayed overnight, for a very long time after midnight, and then he goes to school completely exhausted. And he cannot perform very well, of course, but he doesn't talk about this at all because, again, because of that moralizing, because it's about moral. You don't speak about this. You're not supposed to work when you are 15 or 16. So these are things unseen that we uncover through, and as you say, these are maps that we can pull, and they can come to them. If the teacher knew about this, I think the attitude and then the follow-up will be different.
Yes, it's been really interesting to see what care burdens have been made visible through the pandemic. Sort of middle class, middle-aged women's care burdens have been made very visible, but there are other forms of care burden that still remain invisible, like young adults. So I'm thinking about the sort of after effects of the COVID pandemic. Do you think, in your optimistic moments, do you feel that something has shifted as a result of visibility of care burdens in the pandemic, or do you think things are just the same? Do you see any, and if they are just the same, what are the greatest barriers to them changing?
Well, I would say from a care coordinator's point of view that, like I was saying earlier, that speaking as a family member of somebody and being basically unheard versus coming from an organisation's point of view and then all of a sudden magically being heard over the same context, that because of the pandemic, I would say, and it highlighting that problem, some things that I guess you could say have a positive long-term effect is that I think that there is more support available for people who were otherwise unheard before, carers that weren't listened to. Speaking from my personal perspective, like I would be more likely to approach a carer to say, you know, have you reached out to this organisation? How have you got on with like contacting GPs or social services? And basically listening out for someone to say, no, I've been ignored. And then going, I'll do it for you then, because I have this to back me up. So I would say in that way, yeah, that is one of the effects. And we wouldn't have known that unless the pandemic had sort of, I mean, forced that out of the woodwork.
So the carers that I work with, it's in East London Borough, quite working class. And so a lot of carers are now saying that the thing that they do hope optimistically is, I know it's awful, but because there's like a 3.5 million new carers due to the pandemic, that and the pandemic hit everybody, every sort of working class social area like that. What they're saying now is that they hope that there's more middle class or anything like that, where sort of like professional, you know, well-spoken carer, that, you know, statutory services or government are going to have to listen to them, because there's a different dynamic to carers than previously. So what my carers would say is that they were unheard or misheard or not listened to because they were East End working class, and that you know, oh, you know, we can just brush over you. But now with this new set of carers that are coming in, they're hoping that they can't use those tactics as they had historically. Yeah.
The thing I noticed maybe from joining the cooperative movement around that time was that cooperative model of ownership, which seems to be most people, you know, get behind that. If you know, as soon as you explain, oh, it's a care service which is run and owned by the people who give and receive care, then it doesn't matter what your politics is. Most people think that it's just, yeah, that makes sense, you know, and it's something people get excited by. And actually what I've noticed is how much people want to support and make it happen. So it's meant that we've had a lot of support from a whole different range of people, from on a local community level to just other professionals and experts on different, we're willing to share. There's a cooperative culture anyway, I think, in collaboration with local community networks. But it certainly seems like people are much more supportive of a different model of ownership around care.
Yeah, I agree with that. And just to add as well, like on a positive note, I've made teams or met people that have needed support, people that have been involved in the co-op long before I was involved in the co-op, and they was either investors or they just had heard about it and was like rooting for it, who were then in a position to need support for themselves or for their loved ones. And it's so nice, like almost the excitement that you can feel from people that are like, yes, I love this, I love this co-op, like, and even though obviously ideally nobody ever wants to be in the position where they need support from somebody else, but almost an excitement that they can finally be like, yes, now it's like my turn, because I've watched everyone else benefit from this and now it's my turn too. So absolutely, like the sense of community is so strong. It's great.
Great, yeah, we'll take some questions too. Okay.
I just wanted to say, when you talk about why is sort of unpaid caring invisible, I wonder if there's something in British society about caring and whether it's seen as something that people used to do, maybe sort of pre-war and after the war, and then it sort of fizzled out as our gender roles changed. And I do feel that people that are, I'm an unpaid carer, I'm 24/7 with 2 elderly people, they're really frail, and now I'm palliative care. When I want to speak to a GP, it takes me 4 weeks to get someone to come out for a home visit. If I spoke to Tony, I know that would happen within days. And I think what's sad is that we rely on institutions and agencies to to be our voice. And that's what's sad. I think there are organisations and agencies that can help us, but essentially we feel quite isolated and alone, and we need to be recognised for doing something that I guess it's not valued by anybody, and I understand caregiving in general is not valued by anybody, but it's valuing everybody and their role in society, whatever we do. So whether it's paid or unpaid, it's just I'm not very articulating it very well. But what I mean is I would just like society to understand that because somebody works doesn't give them more credibility over somebody that doesn't work and looks after somebody. I think just because you have a role, you have a job and you're paid for it, doesn't mean that you are more of a person, that you are more of a human being than somebody that looks after another individual. And that's important.
Yeah, I mean, what you're saying is so important, because basically when you have a welfare state that was designed to support workers when they were out of work or they became sick or whatever else, but it wasn't designed to support what goes on that other vital piece of work, which is the work of caring. And that's the basic problem as far as I can see.
But Care Act is that, and I think what I do believe is the Care Act came out in 2014. It's now, it'll be 10 years old next year. I think it's time for a review of it. And I think the most important part of that is missing is that, so the Care Act says that the needs of the carer must be met. Okay, so that's more practically, emotionally, that kind of thing. What I think they're missing is that carers should be heard and should be a vital voice within the care of the person they care for, and that they have to be listened to on an equal basis to professionals. So that's basically what Chadwiga said, that it can't be ignored, because carers know the person they care for better than anybody. And I think that's what should happen.
I just want to say, so I came with Tony. The word, I think that people don't want to be associated with the word carer because it seems kind of old. It seems like you're looking for someone who's in frail, like all the things that come with it. So the reason I ran into Tony is because I didn't even know I was a carer. So I don't live as far away. I live close to my mum, but it becomes a 24/7 thing that you do, and you don't think about anything else. You just think of the care of your parent. So she's losing hearing in one ear. She's got heart condition. She's got high blood pressure. And to look at her on the surface, she seems to be fine. But when you try and talk to her, she can't hear. So it's sometimes taking all that on board and then convincing your parent that all the stuff that needs to fall into space. And the other thing I wanted to big you up on, because there is, as a male, because society says you're supposed to be hard and you're not supposed to, show your emotions, there isn't that kind of group that you need to be able to talk to other people. So when I came to the carer centre, I then realised there are other carers and there are other people that do the same thing that I do. And then it became a kind of, a bit of relief. And what you're doing as well, the Care App, I think it should be nationwide. I think most boroughs should have it, most cities should have it, because, and the comment that you said about it takes a village to look after a kid, I think it takes a village to look after a parent once you look at the other side. And I think that they're so powerful what you're doing, and it made me think that as a male, I don't like, if you call a barman is now called a mixologist, so I need a new word for carers. But we need a new word. Then I can wear it like a badge of honour, and I'm proud of what I do, but I don't consider myself to be a carer. And I know other men that don't consider themselves to be carers that have looked after their parents, relatives that have passed away. And I've said there's a carer centre, and they didn't even know this thing existed. And the other thing I would say, Tony, as well, is the Carers Act is 10 years coming up. Then we need to kind of get this into public awareness, so carers know what, one, their rights are, and two, what they can do or to look out for. So it's kind of that. So thank you very much.
Just said I'm doing a workshop on that on Wednesday.
Oh, cool, yeah.
All right, go on. Yeah.
Thanks. I just wanted to pick up on something that word you used, Lloyd, convincing. Because I don't know, I'm watching my mother care for her mother, who is, and I wish they lived in Clapton, but they and I've watched my mother since my grandfather died in October absolutely become a shell of herself. And part of that has been about, sorry, these guys know about it, but part of that has been because of the miscommunication between my mother and my grandmother, my mother feeling like she has this moral obligation to my grandmother, and my grandmother pretending or not admitting that she needs certain forms of care, not wanting to spend money, so it's all this kind of like this kind of smoke and mirrors that goes on, where they kind of are performing different roles for each other, and they're upsetting each other, and it's all really horrible and and really sad that this is like they're both grieving, all sorts of things. So my question to you guys, particularly to the Equal Care Co-op, but also to you, Tony, and Lloyd and Chandrika at the Care Centre, is how do you manage this messy relational, cultural, moral work? And my nerdy bit of the question is, it's so interesting you use Rocket Chat, because Rocket Chat is what we use. Lottie and I used to work for an organization called SHM Foundation that ran peer-to-peer psychosocial support groups. And we used Rocket Chat because it was like WhatsApp, but you can control, things can be anonymous and you can do this decentralized control. So I was just wondering, how do you do that messy relational bit? And how do you, and how is that maybe facilitated by the digital infrastructure of something like Rocket Chat? Or is it people having to just convince people? Yeah.
Yeah, good question. And I'm sorry to hear about that situation. I'm sure almost everybody in the room has felt the same and seen the same scenes. So in terms of like, sort of what could Equal Care do that could help the situation between your mom and your grandmother? To me, that immediately makes me go back to what Luke was saying, I think to me earlier, about how so in the case of like if someone's got dementia, so in a lot of cases, like the family member or the friend that might be giving support and caring for that person, they are grieving themselves, and therefore, because of that, they cannot give the best quality of support, I suppose, but they need support for themselves too. So they're kind of stuck in the middle. So I think Equal Care, or having a worker from Equal Care, would be really helpful, because it's kind of like a unbiased perspective and involvement. So someone that listens to both perspectives, and we're not judges or the jurisdiction, so we're not going to say, oh, you're wrong, this is right. But I guess having maybe like a buffer or a little bit of pressure off of your mom, thinking, oh, I've got to do this and I need to do that. If she can pass on some of those things, if she wanted to a worker, then your mom and your grandmother can concentrate on their relationship more with. I honestly think one of the hardest things to ever go through or witness in social care is changing in relationship dynamics. It's horrible, especially if you're grieving. Even if that person that you're grieving for is sat in front of you, in some ways that makes it worse. And I think Equal Care, like, we recognise that many of us have been carers or have been care workers for many years, and provide the space, I suppose, to be able for someone to express and say, this isn't happy, like, I'm not efficient where we are right now in our relationship. What can you offer that can help? Like, we're very tailored support. Some teams that we only do virtual advocacy or remote advocacy. That person, that's it, and they can continue having those relationships with their family or their friends, but they have someone else from us that sort of deals with the more logistical side, I suppose, of support. Luke, anything that you would change in that? Sorry.
I guess the only other thing that I was thinking about, which is you know, when it's focused on two individuals supporting each other, whereas thinking about looking at wider support networks is, I agree totally. It's very hard to change dynamics, family dynamics in the stressful situations. So I have very low expectations. It's very occasionally you meet a family carer who's really, oh, I'll try this technique. Oh, adapt my, oh, you mean change the way I'm being with my mum? You know, oh, I'll try that. You know, that's pretty rare. But the other thing is like when we're building a team, you decide as a group, that team decides, so what are the hats that need to be worn? You know, it's basically starting to see care again, you know, name all the different forms of care that happens. There's the coordination of hours, there's the getting materials, there's, you know, all the different hats that tasks that need to be done, and then who's wearing what hats, and that makes it more visible and it highlights a little bit. And also, I think I've heard it a lot in, you were talking about in teams, is sometimes when there's care, if you like, care labor of one kind or another, which is everyone and no one's responsibility, then it somehow doesn't get done, or it's if the one person is always picking it up and it creates stress. Whereas if you name it, at least you can start to have conversations about, you know, the roles people can play.
Yeah, I also, sorry, real quick, just wanted to say that we were talking earlier about moral obligation, especially within families. I don't feel like it's important to say, and it's something that we really advocate at Equal Care. You absolutely can say no, like, no, I don't want to do that. Actually, this is my boundary. I want to have a mother-daughter relationship with this person, or I want to have, you know, a brother-sister relationship. I don't want to be their carer in that way, kind of thing. I think in like conventional care agencies that the support isn't even offered to family members and stuff for that to be an option. But I think that should be a more widespread, like, mind space.
I'm going to say, from my point of view, I've actually wiped the floor with a few social workers who have said to carers it's your moral obligation. So I've advocated and made that, you know, disappear for that carer. But I've just talked from the care centre point of view. So we are quite rare in the fact that we are entrusted by the local authority to undertake the statutory carers needs assessment. It's not very often done, it's normally done by social work teams. So we look at it from a carer perspective rather than a local authority perspective. So the support that we give the carer is very holistic. So out of that, there will be like looking at like the shared labour, you know, the care labour and stuff like that, and who does what and everything like that, and how that is. We then work with the carer around being assertive with other family members about sharing, being assertive with local authority, being assertive with the person they care for. They're also offered psychotherapy. We have an in-house counsellor who then gives them mechanisms for coping and dealing with things like that. We also do some work and workshop. I run a workshop that I developed around preparing somebody around having conversations around lasting power of attorney and will making and funeral planning. I say that, but I told my parents for 12 years, and unfortunately my dad passed away a month ago, and I'm just picking up the pieces because they didn't take my advice. And so I can do it, but it doesn't always work. Do you know what I mean? So like when my parents, they're like, my mum actually said to me once, "Are you sure you know what you're talking about?" And then my mum's now got dementia, and I said to her last year, I said, "You do know I did spoke to you?" "No, you never." Like that. So she doesn't believe that I actually had this conversation. And even my dad said, "No, he did." Do you know what I mean? So yeah, so it, you know, you can. There's lots of things out there, but it doesn't always work. It's hard to have conversations.
Yeah. I don't know. I just have this question. Before yesterday, I visited my friend who had that died. He had dementia, but he fell out the womb. And this is one of the things I see in our community or our culture. Really, there is a little bit shame because you need to be the care of your parents. That is how we grow up. And sometimes what I notice in our community is that shame. I cannot ask for care because there is the guilt and there's a sense of grieving, and it never been not allowed to have that conversation. I was carer when I was
12 years old to my grandma who had dementia. But the question is how you think the care system can having this difficult combination, because there is generation who believe they entitled for their children to look after them. And there is other side, and then look after you, because life is not no more just us and having the life becoming this speed and this responsibility. And I feel like I've seen a lot of family, like my friend, I saw that family, they grieving 3 times because they guilt, did we looked after him enough? And the other question, why we didn't, but it's been going a year and they're all them educated, but the problem, that step, we need to have care of our father. It was never been in the table because the long historic belief and religion, and sometimes there is religious side of it. You need to responsible for your parents too. How you think you can break that conversation? Why you think it's different cultural?
I would, we in equal care, what we try and start to build team, before we build a team, we build a circle. So that circle is a group of people from a community who want to, who are interested in a cooperative model of care, trying to address their needs in what way they can through this team's model. What I imagine happening in London is communities from different backgrounds set up their own circles. The idea that a circle like our current circle could address the complicated needs and understand the cultural nuances of another community who's actually probably only 5 minutes away from where we are. Actually, what we would want to do is support a group to start having those conversations, and ideally have a group that's kind of representative of the local people who are interested in providing care, family carers, so that you can give, it's a forum to enable communities from different backgrounds to launch their own service, but from which they can make decisions together about using a platform that enables them to provide care that meets regulations, because that it's never going to get to scale if it doesn't meet these standards.
What you said resonated so much with me. But the other thing I realized when I didn't realize a couple of years ago that I was a carer was that I've never had this conversation with my parents. I never had this, and then there's a moment that happens, something happens, and it dawns on you that you're now the adult making the decision for your parent, and that to me, it spun my head for a good few months, because I'm like realizing I'm making the better decisions for you now. You're like, not that my mum had dementia, but I was making the better decisions by doing a bit of research on my phone or by talking to Tony, and I'm like, I come back, Mum, this is not what we do, but let's try this. And she's like, oh yeah, that sounds okay. So that conversation is one of the most uncomfortable conversations to have, I think, to be able to go and not to feel guilty, because I had a friend who his mum and dad had dementia, and he was a group of 5, and he was the youngest, and he had to call a family meeting to say who's going to take responsibility for this, because I can't do it all myself. And he was doing what you were doing, traveling backwards and forwards, and it was burning him out. He was getting burnt out, and then you had other siblings that didn't want to admit that their parents had dementia. So then there's the clash of going, guys, there's something serious that's happening here, and we need to kind of look at it. And if they don't know there's no help, it becomes your family or the individual looking after your parents, and that's a lot of pressure, especially in the world we live in. So I totally hear that point. It's like to have that strange but conversation that's needed, and it's when to do it or how to have it. And I think that's a massive point that I never visioned having as a kid. I've got kids myself, like you said, I've got kids myself, and then to know that, okay, Nan can't hear out of one ear, and then you got to explain this to your 2 kids, and oh yeah, but it's Nanny. I'm like, I can hear, but Nanny's getting older now, and my mum doesn't want to admit that she's getting older, but you can see it. You can see it by the things they do, and I'm like, okay, I'm now the adult. I'm now the one who's got to take all of this on my shoulders, but also be the rock. So it is kind of hard, and I totally. You made me think about that. I was like, oh, I didn't like that conversation. I didn't like.
It's why we need these organisations like Tony's to just, just to equip you. Yeah, do you want to go ahead? And then I have a question.
Yeah, I'm Isaac from the LSE
thanks so much. Really, really fascinating and actually encouraging, because I remember speaking to Emma, quite a cohort a few years back, 2018 or 2019, and it's very nice to know that it's coming home to East London. So that's good. My question is, I just want to return to the tension that Laura raised between care's paid work and care's unpaid work. You know, in what you've discussed, you evoke this tension as it plays out in our everyday challenges as those who give care, those with relatives needing care, and so on. But it's also a tension that exists at a kind of a level of national politics, right?
Yeah.
And so, for example, if there's any hope of like a major shift in the fortunes of people who are carers or care workers, it's going to come from a change in the national government via the entry of a party called the Labour Party, which is if there's any hope in the short period of time that will come from that. Maybe we hope not much, but that's something which is on the table. Possibly they've spoken about something called the National Care Service. What that is it depends, right? According to for the trade unions, this is about trying to bring care back in-house to local government. Okay, it's trying to improve the dignity in work for local council employed care workers. It's not about cooperatives. It's not about the third sector, because this is seen as a step backwards. For people who are carers, maybe the concern is more with a much better recognition of their rights, their needs, etc. Now, intellectually, the same tension is there. You have some people who are much more concerned with, okay, 5% of the population works in care anyway. How can we make this well-paid work? How can we bring this as an opportunity to the more depressed parts of this country? How can we have an inclusive industrial strategy effectively around care work? On the other hand, you have people who are maybe more theoretical, who are concerned with post-work. How can we give people UBI? How can we decommodify care work? How can we make it so that we have less working time and more time for everyone to be a carer? So these are that's the intellectual version of this debate that anthropologists think about, but there's a very practical ramification. Now, it seems to me what Equal Care Co-op does is kind of model in a sort of micro-utopian way, a way for paid care workers and unpaid care workers to see their interests harmonized as opposed to in inevitable tension. But I guess my question for you guys, who are all the experts in this, at the level of national political debate, how do we visualize that common interest so that when change does eventually come in a couple of years' time or 12 years' time, the changes that are brought in can benefit everyone as opposed to only benefiting one side of the equation? How do you build a political coalition?
What a stunning question.
And my question was going to which kind of build on yours, Isaac, which is really the question of what would you be able to fit in the short term? Around the ways in which provisioning and care takes place at the local authority level. I mean, there are all sorts of constraints. The ability of people to have the ability to move their care into the private sector, but that doesn't mean you don't have the capacity yet to do that, and there are problems with getting people to make that change. So, if we're going to think about top-down politics, which a really, really important question, which is what is the model here? What can the model be? What is the different, macro model? But what is the different micro model? Like things that you could have a conversation with local authorities about now.
I guess I was thinking, I think those are great questions, and I don't have a clear answer, though. I lean towards UBI. But I think though that it's interesting to sort of think about what because we're talking about how is care going to be bought? You know what I mean?
Yeah.
And I think it was interesting. We started doing this work, really grassroots stuff, and started trying to set up these activities and relationships in the sheltered housing place, and we've built some really great relationships with some of the residents there, and we've made some really great connections. And then the tender came up for the in-house care team in that sheltered housing, and so naive. I was thinking, oh, let's see if we can put in a tender for this, and I looked at it and I was right, the current provider had a turnover of 8 million. They'd lumped one sheltered housing group with another one, so it was a massive scale, and then we would have had to take on the workers of it was just totally, there was no way we would have had a chance, and we would have to be huge really to have a chance for that. And what struck me was the difference between how funding for care, but buying care, and the community development grants I was trying to apply for to get some resources for our group. And they're totally different kinds of questions. And I thought, actually, care should be bought in a similar way as grants are made. You know, like, because usually when you apply for a grant in the world of community development stuff, they ask you, what relationship do you have with the group that you're going to help? You know, how representative are you of that group? What's your experiences of co-production? You know, can you point to some things? Those questions weren't in there. They just sort of add a bit of social value on there, and sort of somehow you make some claims that I doubt they're going to really, you know, evaluate or check up on. You know? But I thought actually we should be moving towards thinking about care through grant making, and then maybe that shapes then what forms of ownership then apply for those grants.
From my perspective, they worked it out on an average year, unpaid carers saved the government 135 billion. Okay, so they call it unpaid carers the second NHS. Okay, so some of that money should filter back down to local authorities so they can invest in. So, for instance, but then also there's another thing that I think should happen is that commissioners from local authorities need to be less short-sighted and need to think long-term. So there was a shortfall in money last year. We got a little bit more money. So we were then invested in more wellbeing activities, which then, as I mentioned, when we did our feedback and surveys, that there was a rise in better wellbeing. But the funding's ended. It ended at the end of March. And so we've gone back down to re-scraping and developing stuff and doing stuff that I can do. Now, what I do think is that, so in Tower Hamlets, the unpaid carers saved the borough 500 billion. Okay, so some of that should filter back down. That investment should happen. There should be investment into carers. There should be a long-term sustainable investment in unpaid carer services. I think that should be across the board. It shouldn't be a telephone in one borough and it shouldn't be a centre in another. It should be a level playing field. I think what should happen is, I like the idea that we work together, you know what I mean? And that, you know, there should be more investment in social care. I think I've heard integrated commissioning and services for, I've worked in health and social care for 4 years. I've heard it, but I can't see any better way of, you know, it's no different to when I was 19. You know what I mean? When I came to London when I was 19. So do you know what I mean? So I think there needs to be less lip service and more action. That should definitely be across the board, and more investment.
It's really interesting because the new integrated care system, which is what I was sort of referring to in the NHS one, you know, you're talking about thing. The problem with that is it's just having voluntary groups as representatives on committees.
Yeah,
you know, that's
definitely.
not giving more funding. That's not, you know, it's just someone has to turn up and be on another committee.
Yeah. Also, and one last thing, it shouldn't just be health and the local authority. The other big player in everything that really needs to come in and be regulated and working is housing.
Yes.
So housing is the biggest letdown in any area. You know what I mean? They think they can work independently and make profits. They need to be more accountable because housing is integral to integrated care.
Yeah, so the budget is there for care provision. But Tony says there's savings, the fact that the budget's set, that means there's money allocated. And if they can, so for instance, I'll give you a story. My mum has bladder issues, she had a catheter fitted. So it means a district nurse come to visit her to treat her. On the second day she got released from hospital, the district nurse turned up and says, I'm here to show you how to flush out the, I said, I'm not doing that, I'm not making change. Now, what makes me think is how many people within the community think they have that duty to do that. That's saving money. So agencies have this thing where they tender all the work at a very lean rate. And that impacts on the care. So I'll have a district nurse who'll come in flustered, irate, and it's not down to the individual being a nasty person, it's just the pressure of, and then I have to be an advocate and say, excuse me, this is my mum.
Yeah.
So I have found myself clashing with people, standing back and thinking, was I right in doing that? So there's all these different things, these different emotions and different things where you're an advocate, you're caring for your mum, you're trying to understand the care system. So it's a very, very complicated situation. And just, you know, your mum who's in Australia, she needs to somehow within her community build a circle, because what she's going to find is that she's going to get burnt out. She has to have respite. And it means setting boundaries, and it's one of the most difficult things I've had to do with my mum. Set boundaries, because you have to walk away and you're thinking, am I doing this? But you have to for your mental health.
Yes, I also agree with what you said. I also want to say that some forms of care in some communities, especially marginalized minority groups, will have to stay at that level. Basically, they have to stay in the intimate kinship environment. They cannot be scaled up because of cultural, religious reasons and others. So sometimes, I mean, in my case, for example, where I know the Roma Gypsy traveler communities and their relationship with the state and the state provision, in a way, it can be detrimental in a way. It could be perceived as a complete overtaking of the community. So I think there needs to be a balance there, and diverse.
Yeah, so what you're saying, Eliana, is really that we need the voluntary sector and these different diversified forms of the voluntary sector. And it was very interesting what Isaac was saying, that somehow the conversation in the Labour Party is that that's an old-fashioned route, even though, you know, it functioned reasonably well under last late period New Labour, which that kind of channeling of funding from central government. So it's interesting that in a sense the thinkers in the Labour Party have kind of skipped too far ahead to the society of complete leisure.
I don't know if the Labour Party says that. The unions definitely say it. You can see why, but they're speaking for workers.
Because they're speaking for workers, exactly. So, I mean, maybe that leads to the question of, do you all think that the voluntary sector is the best place for this to happen, for all of this to happen? Or yes. I suppose my question is there anything that should be taken back by the state that it used to provide, or anything in the future that the state should provide that it isn't?
Money.
Yeah.
Even some of it back to sheltered, what is it, sheltered accommodation? Like, some of this is run by a private firm. And it seems that they don't really care because that's someone's parent. And my mum used to be a carer, and the home I went to, it's like, okay, you've got some families that are full on, like some people in this room that want to take care of their parents, and it broke their heart for their parent to go into that care, and then to not be looked after by someone else, you don't feel really bad, and then you're trying to go through the legal system and say, to make sure your mum's looked after. I think that private care, maybe that start there, and maybe there should be circles in all communities, because there's some people that like to care and help you out and be in contact with those people, so you can have a day off or a couple of hours off without feeling too guilty, because you feel bad if you go, no, I can't, I don't want to do that for my mum, or but you should be allowed to say, I can't do that, I can't physically and mentally do it. So
it seems like we need co-ops, cooperative housing as well as cooperative circles. Yes, please.
I find it very interesting what you said about, are there things that a centralized government should keep on doing? The only thing I'm thinking about here is that the socially organized way of doing this care, it requires social capital, and some people are excluded and do not have this. And then who takes care of them?
It's a really, really important question. I think Isaac, you have this.
Well, I'm just coming back to what you said is the voluntary sector the right place for this? I don't know. In our reading group recently, we read Leah Peepsner Lakshmi, what's her name? Leah Peepsner Lakshmi Samarasinhan, that book, Care Work on Dreaming Disability Justice. And that's like articulating a really kind of clear vision of like care collectives and webs of care, where in order to give care, you need to be sustained and supported. And it's a model of kind of mutual aid, which is in recognition of what you're talking about, Ileana, about the ways in which the state is such a negative force that some communities, you need to take things in hand and do it yourselves. But even in the context of that, like she's prizing open the really corrosive dynamics which come into care, whatever modality it is happening through, whether it's through family, whether it's through mutual aid, whether it's through voluntary groups, and whether it's through the state. And she sort of lands in this position where she's sort of just, you know, articulating this really strong collective model, but at the same time saying, you need to kind of have lots of options on the table and be able to move between. And even within these really sort of radical mutual aid collectives, there comes a point where you're burnt out and you need to have the respite care, which is enabled by the state. And so I don't know. Don't think it's only in the voluntary sector.
That's really, really
We need that diversity.
I wonder if the education system play a role, because the care word is bare, left over of society.
Yeah.
And then some kind of like, for us, the example in the community is the more you get older, the more your hierarchy up in society, you the wisdom, you respect you. And now when we look at care, or it's actually, we need more education more than anything ever, because it's the people not being needed. And sometimes you hear conversation with people saying, this all the people, they don't understand. Oh, they just, no one talks to them. And it's really broken heart sometimes. This is the association with the word care. It's not no more I'm helping you because you're losing your physical ability a little bit. And now we care about you. The word I don't think is mentioned because there is a stigma with it. And how we look at these people, I think some point is just to start an education, because it's the barren people and young people who becoming care in school. I see young people like youth therapy who care, and they feel shame to say that because they cannot say it's no safe place, and they've been bullied in school and how they are. And I think somehow we're bullying these people, we dismiss them, and then the other hand be saying, oh, we care about you.
And it's fascinating what you're saying, Scott, because it shows the difference between the qualities of care when it's associated with the elderly versus the young. And we have to think about these different moralizations of those positions and why, you know, the care for the young is seen as valuable to the extent it is at all, but it is seen as valuable because it's producing, you know, the next generation of workers. But the elderly are, you know, that care is, you know, what is the place of that? Yeah. Yes, it is.
I'm Des Blake from Newham COVID champions. I was just going to ask, excuse my ignorance, but is there such thing as a national carers network, and does it work?
Yeah. There is the Carers Trust. So the Carers Trust is a national organisation that provides information about where a carer can go and what's in your local authority or in your local area. So there is a national carer service network. There are some, I think there isn't, and well, there's Carers UK where they try and patch up carers, and there's online stuff. But the thing is, we go back to there's online stuff, but there isn't necessarily, you know, not everyone's online. So you know, you can't be national, you know what I mean? So there is a role for in-person carer services, because not everybody, you know, a lot of carers are elderly. In my borough, you know, there's poverty, they can't afford internet, couldn't afford a smart device. Do you know what I mean? So they need, you know what I mean? They need to be able to come into a physical centre to be able to get what they need, because, do you know what I mean? So it's patchy. So this is why I always say carer services or what's aimed at carers is not a level playing field, not in the slightest.
Thank you.
Just quickly say, so my mum had a stroke and overnight we became a carer. There are large numbers of people, we're talking about care here and it over a certain amount of time. There are large numbers of these carers who become carers overnight or within a second and a minute, and they're not given a choice, that it's a closed choice.
Yeah.
And so we do talk about this kind of, you know, we can debate whether we want to give somebody that opportunity to say yes and no and boundaries and what have you. A lot of the time we're in hospitals or we're in an ambulance or, you know, we're in these settings where we're not given a choice as to what's going to happen to our loved one. We're going to have to look after them. So care is very nuanced and it's very broad. And so I just wanted to say that just so that we didn't think that we're caring for people gradually. We are, but sometimes we're literally stepping into it the next second.
In our care centre, a lot of care, they use this sentence quite a lot. So they basically say you're basically one incident away from being either a carer or a cared for. That's it. You know what I mean? And a lot of our carers say, when I left school, I never set out to be a carer. That wasn't on my CV. You know what I mean? So yeah.
I think with what the lady said earlier about maybe let's start with education. Maybe let's start with infomercial videos that kind of make it okay. Because at the minute it's not looked at that from my point of view. It's not looked at as being, oh yeah, when I get to 40 or 30, I'm gonna be a carer. So I think I'm gonna change the words there. I'm gonna call us careologists.
Drink related care by the time.
Okay, that's brilliant. Now we've got a word for the new movement that we're deciding. That's great.
Careologies, that's what you're doing, and then you're careologist.
Yeah, so thank you so much. I want to thank the panel and the audience as well for a really, really wonderful conversation. And I'm left feeling probably more optimistic than less optimistic, which is the program discussion. And I feel that there's so much that this space of care is opening up as an issue for everybody. And probably I'm going to go home. I don't know how other people. I'm going to go home now and draw one of those care maps. Yeah, that's the first way to raise our consciousness. So
I kind of call that you have the care map to see how much you care. Then you take a deep breath and go, right, family, let's come to this. We need to sort of circle.
Yes, yes. So thank you very much. Yeah,
I guess. Deterioration, you think about sort of the